Hello everyone, I am Dr. Deepak Talwar. I am Secretary Indian Chest Society and I am a pulmonologist working at Noida Metro Center for Respiratory Diseases. There is an association between API and ICS to provide respiratory updates to physicians, and it has formed a body called Apics. Apics webinars are coming your way, and considering the high interest and emphasis on the lung health in the current times, this is going to be a monthly series. Twice a month, it will be coming on 2 Saturdays, and it aims at providing a complete update on advances and diagnosis of management of some of the respiratory diseases which are of importance to our physicians as well as respiratory physicians. This will be based on case-based discussions and what we routinely encounter in our daily practice. So this webinar is going to be a great way to help us enhance our knowledge to treat our patients. And of course, this seminar is aimed at not only physicians but also respiratory physicians, and hence we'll have mix of physicians as well as respiratory physicians discussing it on the table and giving the messages which can be implemented in our daily practice. So do join in for this Apics webinar, which is going to be on 11th March, 8 p.m. onwards. And the knowledge partner for this is Glenmark.
Hello everyone, it's my immense pleasure to welcome you all on this API ICS Respiratory Update online series. API and Indian Chest Society have joined hands to pursue the common goal to update the knowledge of respiratory physicians and practicing physicians in the field of respiratory medicine. There has been a spurt recently in respiratory cases and post-COVID complications, and a need was felt to update the knowledge of practicing physicians at a grassroots level. And I hope this online series of respiratory update will go a long way in achieving this goal. We will organize these programs at a regular basis as a case-based discussion, and will invite distinguished faculties to share their knowledge and skill. I compliment and congratulate Dr. Deepak Talwar, Secretary, Indian Chest Society, Dr. Jyotirmay Paul, Dean, Indian College of Physicians, and Dr. Agam Vora, Secretary API, for taking this wonderful initiative. I welcome you all again this evening and extend my best wishes for this program.
Welcome all the delegates. I am Professor Dr. Jyotirmay Paul, Dean, Indian College of Physicians, that is the academic wing of Association of Physicians of India. I welcome all the physicians and students to this joint symposium of Association of Physicians of India and Indian Chest Society. It is my intention to enable different associations to come together and organize such collaborative endeavors for the advancement of knowledge and mutual exchange of wisdom that will ultimately lead to upliftment of standard of medical care. Hope this joint symposium of Association of Physicians of India and Indian Chest Society will update our members on the recent advances on respiratory medicine. Jai Hind, Vande Mataram, long live API, long live Association of Chest Society. Thank you.
Ma'am, you may start.
Good evening, everyone. It gives me immense pleasure to be here again this Saturday evening for our third in the series of this Apics webinars. This month, we are going to be discussing the topic on sleep apnea. And it gives me great pleasure to have a distinguished group of people with us for this discussion. First and foremost, we have Dr. Dipti Gothi, whom I have known since my post-graduation days. Avid academician, she is a professor and head Department of Pulmonary, Sleep and Critical Care Medicine. She is also the Director, Institute of Occupational Health and Environmental Research, ESI, PGI MSR Delhi. Welcome, Dipti. Along with Dipti, we have two panelists with us. We have Dr. Manas Mengar, who is a consultant and a sleep specialist at Jupiter Hospital and Thane, and Fortis Hospital in Mulund. Manas has done his DM from Delhi and is specialized in sleep medicine. We also have with us Dr. Supraja K, who is from Chennai, and she's a consultant and head of respiratory department at the Madras Medical Mission in Chennai. And we have two young budding pulmonologists with us, Dr. Anshu Priya, who is a senior DM resident at the KEM Hospital, Mumbai. And we have Dr. Alina Varghese, who is a senior resident at Jupiter Hospital, Thane. And for those of you all who don't know me, I'm Dr. Pratibha Singhal. I'm a pulmonologist from Mumbai. So with that, I welcome everybody, and I think we should start our first case. Dr. Anshu Priya will be presenting our first case.
Yes, ma'am. Thank you, ma'am. Am I audible?
Yes, yes, yes.
Okay. Good evening, everyone. I'm presenting first case today. I'm Dr. Anshupriya from KM. So my patient was a 48-year female who has been diagnosed with asthma with systemic hypertension and pre-diabetes. She presented to KM OPD with partial control of asthma while on inhalers and uncontrolled systemic hypertension while on antihypertensive medications. So on probing with questions related to common causes of partial control of asthma and hypertension, we found that she was compliant to inhalers and both antihypertensive medications. She didn't report any sinusitis, rhinitis, or recent exposure to dust, fume, biomass, or GERD. But her response was yes to many questions related to sleep disorder breathing, like excessive daytime sleepiness, fatigue, early morning headaches, nocturia, and snoring. Otherwise, she had no addictions and she was a housewife not employed anywhere. So the first question arises is, what are the symptoms of sleep disorder breathing?
Great. So, Supraja, maybe you would like to help us with this.
She has to unmute.
Yes, sorry. So can you tell us on the BMI of this lady, please?
Yes, ma'am. Actually, I've kept that part for general examination.
Okay. So ideally, any symptoms of sleep disorder breathing will be it will be snoring, which will be observed by the family members, and witnessed apneas. Patient will start complaining of excessive daytime somnolence, fatigue, unable to concentrate. So predominantly in the clinical practice, they will come with, if they're sitting in meetings, they'll start dozing off. And while they're driving, they will sleep off in signals and they'll sleep off in the car. So these are clinically, this is how the patients generally present. And yes, there is definitely a dry mouth, when they are having an open mouth during the sleep, they will be having. So yes, these are the classical symptoms of obstructive sleep apnea.
Yeah. Should I go ahead?
Dipti, you have any further inputs on this? Please do join in.
I tell you, yeah, exactly. I guess by mistake she asked a question, but that's what I was trying to tell her, that there can be, unusual symptoms also. So especially you have a patient of asthma. Now, if a patient of asthma is there, that asthmatic will have breathlessness when they have uncontrolled asthma too. And when they have uncontrolled asthma, they wake up. But the difference between the asthmatic who wake up because of asthma versus they wake up because of obstructive sleep apnea, you can make out from symptoms by going deep into it. So those who have nocturnal symptoms of asthma would be kind of getting up. They will be having a little bit of cough. They may have incessant cough, and they may kind of, be breathless for a long period of time, or for some time at least, till the time they take inhaler, or they, it reduces a little bit, the intensity of breathlessness reduces. Whereas that, because of sleep apnea, they'll wake up and they'll feel kind of choked and they'll be okay after they wake up. So there is a difference between asthmatic who get up. So when you take this history of nocturnal awakening or nocturnal, difficulty in breathing, you have to go deep into it and find out for how long they feel that, and what other symptoms are there associated with it. That will help you better understand asthmatic with
Correct. Great.
apnea or diarrhea.
Yeah, so great input, Dipti. And I think some other systemic histories also, which we often forget, in our patients, asking them about their mood, whether they're irritable, whether they are having, memory loss, whether they are having difficulty in other cognitive functions at work. So some of those, like sometimes patients may not give us that history, but or they could sometimes, occasionally, we've seen actually come to us saying that I have these issues, and incidentally, somebody has noticed I'm snoring in my sleep. So I want to get assessed for this. So those are also important things from a patient perspective. Depression, mood disturbances, those are important from their perspective. Like we get very fixated on medical issues, what happened, but for patients, it's more about what is happening to them on a day-to-day life. Yeah, please go ahead.
Can I add few more points to it?
Yes,
the presenting history. So one of very important points I would like to put forward to my physician friends. My boss and mentor, Dr. J.C. Suri, he used to say, anything refractory, any systemic disease which is refractory, always explore a sleep angle to it. My friend, a neurophysician, he was managing a patient of migraine. But, with all the medication exhausted, headache still persisted. And he did explore, and patient had a sleep apnea, which the headache resolved after. Similarly, for a cardiologist, a case of resistant hypertension, then a case of decompensated heart failure getting frequently admitted. Sleep is a thing which touches all the specialty, and presentation to us in the OPD, in a sleep OPD, could be because of uncontrolled systemic diseases also. Thank you.
Great. Please go ahead, Anshu.
Okay. So in examination, we find she had a pulse of 90 per minute, was regular, BP of 150 by 90, mmHg, and respiratory rate of 14 per minute. And she had a bilateral vesicular breath sound with equal air entry on both sides. And BMI she had was of 32 kilogram per meter square. And on modified Mallampati grade was 2. And neck circumference was 14 inches. And waist circumference was 85 centimeters as noted at the time. So my next question is...
Yes, Dipti.
I think I should be asking the questions. Go to the question. So what are the key elements in the physical examination of suspected cases? Or what are the things that you would suspect on a clinical examination, apart from that you mentioned, or highlighting what you mentioned, would be important to look for in a patient whom you are thinking that he or she has obstructive sleep?
Your voice is too low, ma'am. I'm not able to hear the question. The last part of it I didn't hear.
What are the physical examination points that one would suspect in a case of obstructive sleep apnea? What are the physical...
Okay, the glaring things, like when a patient comes and walk-ins to your OPD, the stature, the gait, the neck circumference, the central obesity, and the double cheek predominantly, which is there. And on an oral examination, a large tongue, and enlarged tonsils. Even pediatric, they come into the OPD with a snoring history. So looking into the throat. So the basic general examination half the time will give you a very good clue as to what you're looking into. Even otherwise, even if the patient is not complaining, as the others pointed out, if you're doing a general examination and then ask whether if you're not able to see the back of the uvula and your madras, yes, course of Mallampati. But a simple thing, you look into the oral cavity, you're not able to see the uvula, you're not able to see the posterior pharynx, then yes, there is a possibility of an obstructive sleep apnea that we are dealing with. And short neck, stout men and women with a increased neck circumference, they're all high candidates. And the general examination per se, I think, gives a good amount of clue as to your swelling of the feet. Otherwise, indicating organ failure, right heart failure, should be throwing light into it.
There are a few more things that I would like to state in patients, because always patient has to be the center point. Now, if you're talking about obstructive sleep apnea, with these kind of, pure obstructive sleep apnea, these kind of symptoms would be like, yes, agreed. The chin which is receding back, retrognathia. But in a patient who is asthmatic, one must remember that even small amount of, change in the saturation. Asthmatic would be having a normal saturation, but if you have a comorbidity with obstructive sleep apnea, the chances are that the patient would have a lower saturation. The chances are that the patient will not have these classical signs and symptoms. Patient may be just simply mildly obese. Patient may be simply mildly having a increased neck circumference, because when you have underlying respiratory disorder, the chances are that obstructive sleep apnea, mild or moderate, should be treated and picked up. These are the classical signs of maybe even severe obstructive sleep apnea. But mild and moderate obstructive sleep apnea, if they are picked up, the quality of life improves, the lung function improves, the control of asthma improves, and exacerbations are reduced. So one must look into even a mildly increased BMI with probing questions like history of snoring, etc., history of little disturbed sleep, etc. You should ask the partner about the history of whether they snore, etc. So that should be kept in mind, that not always will they have all the classical symptoms.
So I would like to chip in. So I work in a cardiac hospital. So as you rightly pointed out, the BMI might not be the indicating factor, but because it's two general physicians, so at least when you see somebody obese, that's why you have to think about it. But when people walk into my OPD, so they'll just come with palpitation in the middle of the night with a brief breathlessness, which keeps repeating again and again. So we do see, SVTs which are happening and atrial fibrillations which are occurring along with OSA. So then, because it's a predominant thing in my setup, I do suspect of OSA, treat them, and there are good results with that. Yes.
Right. Anybody else wants to chip in?
That's good points that everybody has brought out, that, but these symptoms and these presentations and examination findings are very classical of obvious patient, but sometimes you have to probe in and find out if you have, as Manas also said, that anything that is uncontrolled systemically or in the respiratory system, even small changes will have to be actually investigated further for coexistent sleep apnea, because we know that we do have an asthma phenotype where mild amount of obesity also, especially in women, and this is a female patient with asthma, could, even a mild sleep apnea could be making her asthma worse. Yes, please go ahead.
Okay. We have kept one more related question.
What are the risk factors that you think of in case of obstructive sleep apnea? What are the things that one would say that these can lead to obstructive sleep apnea?
Yes, Manas, maybe would you like to chip in?
Yeah. So, apart from all the findings of the physical examination which we have described, obesity being the most common, in the pediatric age group, we frequently find tonsils, enlarged adenoids, which does contribute to the sleep apnea. Male gender has been, shown to be at a higher risk. Thin, slender individual with a longer neck also has some, disadvantage at being predisposed to sleep apnea. Apart from this, a good, detailed history about the patient's habits, like alcohol consumption, smoking, they also can aggravate the existing sleep apnea. Patients' medications, we see a lot of patients visiting the physician's OPD or, any OPD frequently prescribed anti-anxiety, antidepressant pills. So, we should always make it a habit to discuss with our physician colleagues that they should be evaluated for sleep apnea, because a case of depression who is being prescribed antidepressants and not being evaluated for sleep apnea, we are actually pushing it more, not helping the patient out. So I feel the medication history, the addiction history, and the physical examination, someone with allergic rhinitis, worsened allergic rhinitis, a flare up of the allergic rhinitis, they are also at the risk of aggravated sleep apnea, or pushing them towards the moderate to severe sleep apnea range.
Okay. Should we move ahead?
I guess so. We should move ahead with our next question. Can you hear me better now?
Yes, it's better.
Yes,
Thank you. Much better. Yes.
Yeah,
Thank you. Anshu, please move ahead. Yes.
Yes, ma'am. Next comes the fourth question.
So why and when do we need an upfront evaluation of obstructive sleep apnea? When do you think should we go ahead with in this patient, should we go ahead with the evaluation of obstructive sleep apnea? What does one think? What does the panel think? What does both the Dr. Manas versus Dr. Anshu Priya, what do you think of when do we need to evaluate? Do we need in this patient, and how do we do it?
First of all, we already discussed on those points. We have discussed about the obesity, we have discussed about the systemic diseases. I would say that a common patient coming to our OPD, referred by anesthetist for surgical fitness, that is the reason we need to check and evaluate. Person referred by a cardiologist for resistant hypertension. Most commonly, the patients who are coming to us with symptoms of excessive daytime sleepiness, daytime fatigue, patients of anxiety, depression, referred by a psychiatrist. A lot of other systemic disorders. So we have discussed the symptoms of, already discussed in detail the symptoms of sleep apnea. So anyone coming to our OPD with all those checklists, merits further evaluation for sleep apnea or sleep disordered breathing. And I strongly believe, in our country, the present trend, no one with mild or moderate disease is going to land up in our OPD, except, insisted pre-op by the anesthetists. So most of the patients who are coming to us, they are in the severe range or with some comorbid illness. So these are the patients I believe should be, posted for level 1 or at least attended portable polysomnography studies.
Right.
Yeah.
Yeah. So we say 6 cardinal symptoms, right? I think we should add snoring as part of the questionnaire for everybody in our setup, because the number of comorbidities that we are seeing on a regular day-to-day basis is quite high. So the existence of OSA is kind of underestimated and underdiagnosed. As I said, unless you ask, you will not find out. So whether we should evaluate is a separate thing, but at least the clinical history part, I think we should be, we should scrutinize people clinically if we're looking into it, and also medically if they're uncontrolled. In this patient, she was partially controlled even on inhalers. So the techniques, yes, we're going to look into it, asthma control, but also the hypertension, she says she's taking it, but then why it's uncontrolled. So that's when we start probing into the other questions of OSA. We need to be making it as a part of our routine questionnaire.
So I think the basic essential thing is that we are probably not diagnosing as much OSA. We are missing out, probably that the OSA that is there, because we are also not, I'm sure when these patients land up to a pulmonologist, we will land up asking a lot of these questions. But I think sometimes when we are so concerned about managing their diabetes, blood pressure, cardiac issues, we forget that this could be also one of the causes which could be leading to uncontrolled, systemic diseases. And I think that is what everyone is trying to say over here, that yes, in these patients, we must, as physicians, you all please must help us diagnose this condition and pick it up much more. Yes, please go ahead.
So the scores which we use for our patient first were measure of sleepiness, which Epworth sleep score, which came out to 15, and OSA prediction score, stop bank score, which came 4 out of 8 points. So here comes the next question.
What are the scores? Yeah. So I personally believe we can ask Manas and Anshupriya also for their inputs. These scores that you mentioned, yes, of course, they are very important in a patient who is de novo or let's say hypertensive or something like that. But these scores are less important when you have an underlying a patient with bronchial asthma or let's say COPD. Somebody who has obstructive airway disease, these scores take a second precedence over the actual history. So yes, you must go ahead and ask for the scores. What are the different scores that you would say, Dr. Manas or Anshupriya? Anything that you would like to include in them?
So I think the common scores which we are using, let's not complicate it, Epworth sleepiness scale, it's just to measure the daytime sleepiness. I would like to discuss with the other panelists also. I find a lot of patients who are, they are obvious case of sleep apnea. they are having symptoms of that, they will not really report the daytime sleepiness. I don't know how relevant these scores are. So, clinical examination, thorough clinical history, good history and examination, they are the first. These scores are just supportive. And Epworth sleepiness score, basically, we ask the patients about the 8 different situations, and it's like self-reported score. We make him score it from 0 to 3, depending from no sleepiness in that particular situation to a he'll definitely go to sleep. And score of 10 or less is normal. More than 16, yes, I can label that patient is having severe sleepiness. But I really doubt it cannot replace the thorough sleep evaluation. It's just part of the process. And regarding the stop bank score, it is a wonderful score, mainly used by the anesthetists for the pre-op evaluation. It has a good sensitivity and must be part of all pre-op screening processes, and maybe evaluating the patient in the OPD, quickly evaluating a patient in the OPD.
So I think the sensitivity, if I may add something, because the Epworth sleepiness score is more dependent upon the patient's answers, right? So I think both these scores are usually used as a screening tool. But when you have a patient who is obviously, giving you history or has other findings to suggest sleep apnea, these scores being positive are not as relevant, at least the Epworth sleepiness scale, because this is very dependent upon the patient. And often, as Manas, you rightly said, patients under-report their actual level of sleepiness. So, this may not be a good correlator of but the stop bank, yes, definitely as a screening for physicians. I think this is a good questionnaire. I mean, what do you say, Supraja? And
yeah. So I wanted to chip in because denial is a significant thing in our system. Okay.
Yes.
They underplay pain, they underplay breathlessness, they underplay. In fact, they'll be in frank pulmonary edema. They will say, "I'm okay. Only if I walk, I'm breathless." So denial is a big thing. The screening things, yes. See, even snoring and daytime somnolence, half of my patients deny. The attendant is the one who says no. The patient keeps sitting and dozing off in front of the TV. So they feel that it's a social embarrassment to even come up with the symptoms. So the Epworth sleepiness scale, as you said, see, it can be used in screening purpose. In fact, for our because it's a cardiac center, we use it extensively, the stop bank, but we do go by the clinical evaluation predominantly and the history taking.
Correct.
I
Yes.
would just, I would just like to, for the benefit of the audience, ESS, that is Epworth sleepiness score, is sensitive but not specific.
Correct.
It may be useful to just generally evaluate whether the person is sleepy or not. In insomnia patient, also ESS can be high. In any person like RLS, etc., restless leg syndrome, etc., the Epworth sleepiness score is generally high. It is to evaluate the quantum of the problem that the person is having at the night, even those who are having nocturnal awakening. So that is just a screening score. Whereas stop bank is more useful, it is more helpful, and stop bank is also helpful in finding out a patient who should undergo the level 1 study versus a patient who can have a home sleep study. So stop bank of 5 or more indicates and patient doesn't have comorbidity would go in for a home sleep study. Whereas if they have a stop bank of less than 4, etc., then they should have an in-lab study. So that is useful for that. So both these scores are important. However, more important is definitely the history and your inkling into the patient could be having obstructive sleep apnea if they are slightly overweight, especially asthmatic. Yeah, you can go ahead.
Okay.
Randall, yeah.
Next question, moving on to the lab of our patient. Her chest X-ray and ECG were normal. She had a fasting blood sugar of 112 milligram per deciliter, HbA1c of 6.2. TSH was normal, but lipid profile showed raised cholesterol, triglyceride, and low HDL. PFT, she was just mildly obstructive with FBC of 72. And on 2D echo, it came normal. So the next question is, what are the routine lab investigations?
Anshu, let Dr. ask the questions, please.
Okay, ma'am.
What are the routine lab investigations indicated for workup of or suspected sleep apnea? What are the investigations that one should go ahead and do it in patients whom you're suspecting? I would like to ask Dr. Supraja.
Yeah. So there are no specific tests, blood tests, which are available for the obstructive sleep apnea. Otherwise, if the patient is abnormally obese despite treatment, you can actually look into basically thyroid and the other factors which can put on weight. Your cholesterol is the other thing. But when you're, these do not point towards OSA. So basic screening tests, in this case, as you mentioned, you said asthma with partial controlled asthma with on inhalers, right? But so the PFT is actually not that bad. Yeah. So in a comorbid condition, especially a respiratory, yes, please do the pulmonary function test to ensure that the patient is adequately treated for the respiratory condition. For OSA, with the history, I think we should go in because this lady, she has hypertension, she is obese, and despite treatment, it's uncontrolled. So I think with comorbidities, it's preferable to go in for the level 1 for this particular lady. And other tests are only to more in terms of control of your asthma and your other comorbidities rather than treatment of your OSA.
Right. We can move ahead. Yeah. Why is systemic evaluation important in a case of OSA or vice versa? That is evaluation of OSA in a patient of hypertension and diabetes. In short, what are the systemic disease that one should look into that may point toward asthma, Dr. Manas?
Yeah, ma'am. So I think we have already discussed on this point.
Yeah.
It's a two-way relationship. Poor sleep, someone with sleep apnea or sleep disordered breathing has a propensity to gain more weight, and the more obese the person is, it will worsen the sleep apnea. Someone with anxiety, either primary anxiety disorder, because of the poor sleep, insomnia, will gain weight and will add insomnia. Will add insomnia to the existing OSA, and similarly, OSA can lead to anxiety. So I feel all the sleep is a villain which is present in all different body systems, and they have a two-way relationship. So it is very important to evaluate, a patient thoroughly, not only with the tubular vision of sleep disorder breathing or as an OSA doctor, but, other body systems and the control of other disorders too.
Right. So, yeah, of course, patients with hypertension, etc. One important point I would like to raise is that it's a two-way relationship, means one leads to the other and the other leads to the first one. That's what you mentioned, right? You can go ahead.
1 second, I'll just chip in. So, can I?
Yes.
Yeah, sure.
So, of late, we are seeing a lot of change in these schedules or the shifts in which people are working. So, insomnia can be because of the continuous change in the shifts that is happening. Because within a week, when they're going to keep shifting between morning, afternoon, night, the sleep cycle is also going to get affected. And a lot of people work in BPOs where the predominant schedules are like they call it as graveyard shifts. So we need to ask in detail about what is the shift, how is the sleeping pattern, and for example, all of us have sleep technicians, right? So our technician predominantly they are awake in the night, and if you look at their quality at the end of 10 years of my own experience, my gentleman, he has gained weight, his quality of sleep is bad, and he's slowly developing because with age he's developing other diseases as well. So everything is interrelated. So a bit of history into the occupation, the schedule of the sleep, and even if they go to bed and how long do they take time to switch off their mobiles, all those into the history, because Manas mentioned on insomnia, a lot of other things also come into play because for the sleep quality.
Yeah, right. I think we should move ahead faster. We have one more case, I guess. So yeah.
So next, we decided for definitive diagnosis of OSA. We decided to go ahead with a level 1 sleep study in our PSG lab.
What are the levels of sleep study? I think we've been saying level 1. I think Manas, maybe you can throw a little bit light on that. What are the levels?
So level 1 sleep study is the gold standard. What we measure is around 7 to 8 parameters: EEG, EOG, and chin EMG and leg muscle EMG. This help in staging the sleep, which is very important. You can, the EEG pattern or like seeing the hypnogram, the pattern and the architecture of the sleep, it does point out towards some disease cues. Like you may diagnose a patient of depression, you may diagnose a case of, it may suggest a case of narcolepsy. So this is EEG, EOG, EMG. Then you have a snoring electrode or a snoring microphone, which picks up the snoring sounds. Then to measure the airflow, we define apnea and hypopnea by the airflow and snoring. So it's oronasal thermistor and cannula, which measure hypopnea and apnea respectively. We have RIP belts, which measure the muscle effort. We have position sensors. We have pulse oximeters. We have ECG. So this is a robust data. Plus, if this has been done in lab, supervised by a technician under maybe video recording wherever necessary, it is the level 1 study. That is the gold standard, and it is recommended for all severe cases of severe sleep disorder breathing, which form the main, and any person with sleep with comorbidities. This is the recommended thing. Level 2 is the portable one. It is all the same things, but it is unattended. Problem with this is, suppose patient gets up, he's having some discomfort or some lid, electrode chips off. Next day morning, we miss the data. So that is the limitation. Otherwise, level 1, level 2 are same. Level 3 is mainly cardiorespiratory studies. We just monitor 4 parameters. That is oxygen, flow, and muscle effort, and SpO2. This is what is measured in the level 3. Level 3 is not a very good screening tool, but it may be useful in follow-up of like either a patient is a very obvious case of sleep apnea with no other comorbidities and no other sleep disorders with it, then we can go for a level 3, or we can use it in monitoring our treatment, follow-up of the patients who have been prescribed the PAP devices. Level 4 is just measurement of one of the parameters. We have recently night OL, which has been started by ResMed. It is not a good screening tool. It has poor sensitivity and specificity. What presently I'm using it is to measure sleep-related hypoxia in patients of ILD, or sometimes to monitor my treatment for the patients whom I have prescribed the PAP devices. So level 1 remains the gold standard. Level 1 is the study which we require for most of our patients coming to our OPD. Over to you.
Right. So you in detail elaborated level 1, 2, 3 studies. I think you've done a fair elaboration. We can go ahead with the next slide, please. Why should we have done a level 1 study in this patient? I guess we have been very clear on this aspect that level 1 in this patient, because of obstructive sleep apnea and bronchial asthma together, anybody with a underlying disorder should undergo that. Should we have a split night study in this patient? What should have been done? I would like to ask Dr. Supraja.
Okay, so split night study, to begin with, initially first half of the study you start with the monitoring, and when you notice that there is a significant amount of AHI which is noted, then we switch on to titration, where we connect the patient onto a CPAP device, which is a continuous positive airway device, and then start titrating as to what level of what pressure is the time when the AHI is getting obliterated. So yes, in this lady, this depends on the results of this lady. If I can have those results, then yes, whether it should have been done, yes. This is
This is the report. I'm coming to the report. It showed a total recording time of 365 minutes, a total sleep time of 206 minutes, leading to a total sleep efficiency of 56.5%. And her sleep architecture, she spent in maximum time in N2, and REM sleep was reduced to just 12.6%. And during diagnostic portion, we observed 40 obstructive apnea and 47 hypopnea, with total index coming to 43.3.
So since this is a significant amount, a split night study is definitely justified in her case. Reason why we should do a split night is predominantly the sleep labs are a little bit overloaded. So you can combine it in a single day. The cost for the patient is saved, and the lab is available on the next day for the other person. But this should have a robust first 4 hours where you are able to get a good reading, and the AHI is also pretty high. Only then we can go ahead.
Yes, ma'am. So we converted after 3 hours to a split night study.
I had a question for you, Anshu. Why was
Yes,
the
ma'am.
sleep efficiency low?
Ma'am, she had a sleep onset of 14.3 minutes, and her wake after onset was 13.5 minutes. Plus, she also had many arousals. Actually, arousal index I haven't put in this slide. It was high.
Can we move ahead?
Yes, ma'am.
Yeah. So, Dr. Manas, I would like to find out from you that what are the diagnostic criteria of OSA, and another question is next to that, because we are really running short of time. Can we go? Is it up to 8:30? I would like to ask
It's still 9
Pratibha.
o'clock. It's still 9.
It's still 9. Oh, okay. So that means we have only 15 minutes for the next. Yeah. So we can quickly go ahead and combine both the questions. That when do you diagnose OSA, and what is the difference between the AHI and RDI, respiratory distress index? And one more, the sleep efficiency. What is the importance of sleep efficiency, and why in this patient, if sleep efficiency is low, what would have one level 3 study, that is without EEG, would have happened if the patient was sent with a level 3 study at home, since the sleep efficiency is low. So can you throw a little bit of light on these three things quickly?
I'll just finish it in
Just
short.
have 2 minutes. Yeah.
We have to diagnose sleep apnea. We cannot diagnose it clinically. We require a polysomnography. So apnea, hypopnea index, that is number of apneas, hypopneas per hour more than 5 with symptoms of sleep, or some patient is coming to me for screening and his AHI is more than 15, but he doesn't, clear those checklists. Then I can label if it is more than, RDI is more than 15. What is AHI? AHI is number of apneas and hypopneas per hour. It's like I'm driving a car at 60 kilometers per hour. I might have driven it for 15 minutes, but that is the average speed. So that is AHI. RDI also includes RERA, that is respiratory events related arousal, which includes snoring and all in addition to it. What was the next question, ma'am?
The next thing is that how the sleep efficiency could have affected the home sleep study when you had done no EEG, or when the study was done without an EEG, how it would have affected this patient.
Right. So sleep efficiency is something which is very important, because that is a marker of sleep deprivation. Patient is coming to me with a reduced sleep efficiency. So this patient, home versus level 1. Patient is asthmatic, patient is having other comorbidities. So level 1 was gold standard for the patient. Patient had I think normal sleep latency of 14. So insomnia was not the issue, but patient has frequent awakening. It has patient ka agar apn sleep, we see the pie chart, N1 is more. That is showing that patient has high number of arousals. So one thing which suggests me is possibly patient has high number of events, one, and second, patient was not comfortable with the sleeping environment. This is the benefit which we get in the home environment. Patient might have a more REM sleep, one, and second, maybe the disturbances or the arousals because of the discomfort in the sleep environment might be less. So this is a difference. But still, level 1 is recommended for this patient. So I would suggest that if we could do a attended portable study for this patient at home, would have been a better one. Could have been a better one.
So can I add something here?
Yeah.
I think as far as sleep efficiency is concerned, when we do a home study, sometimes you get patients who are obviously sleep apneic, but when you do a home study, they come there, they don't fit into the category of sleep apnea, which was just described. And that sometimes happen if, we may miss patients, because sometimes at home, when we are not doing the EEG recording, we'll not realize that the patient has not slept at all. And therefore, we may actually miss sleep apnea. So it's not so relevant in this patient, but in other patients, when we are doing limited channel studies at home, level 3 studies, we could actually miss sleep apnea, because our AHI and the RDI will be normal, because they have hardly slept at all. And that is where these EEG channels also come into this thing. So when you have an obvious patient, you are clinically suspecting, you have all these criteria which we have been discussing for the last 25 minutes about when to suspect, when to think, when what, and you have a home study. If you have done a home study which is negative, please don't just send the patient away. Please do a dedicated in-lab study is what I would recommend. And you choose your patient correctly. You know, if you have a patient who has multiple comorbidities, you would preferably want to do a supervised sleep study with the correct channels.
I would just like to say in one statement that total sleep time becomes actually total recording. Actually, total recording time becomes a total sleep time in home sleep study. So total recording time cannot become total sleep time. That's the and at when you do it in lab, then total recording time is different and total sleep time is different. So that's the main difference. We can move ahead with the next one. I think we have only 15 minutes for the next one. Yeah.
Final diagnosis was asthma with pre-diabetes with uncontrolled hypertension, severe OSA. So I shall be completing my slide. Now, switch off my screen share.
All right. Okay.
Yeah.
So while we are waiting for Dr. Alina to start the second case, I think quickly, Manas, if you want to tell us, Alina, can you start your screen share? Meanwhile, Manas, if you can just tell us, how would you grade this patient had a very high RDI? How would you grade the severity of sleep apnea based on the readings?
So, ma'am, I believe 5 to 15, less than 5 is normal, 5 to 15 is mild, 15 to 30 of AHI is moderate, more than 30 is severe. It's just a number. We need to add, we need to analyze much more data which we get from sleep study. The duration of time for which patient was hypoxic is also important. Maximum oxygen desaturation is also important. Arousal index is also important. Here we are just focusing on AHI. What if the patient is having PLMD or restless leg along with the sleep apnea? If I just treat his sleep apnea and ignore his restless leg or PLMD, then patient is definitely going to come with the same symptoms of daytime sleepiness and fatigue. It would resolve. So, but as per classification, less than 5 AHI per hour is considered normal. 5 to 15 is moderate. 5 to 15 is mild. 15 to 30 is moderate, and more than 30 is severe.
Anshu, I think you have to stop sharing your screen so that Alina can share her screen, please.
Yes.
So, till Alina shares it, there are patients of REM-linked apneas who are symptomatic. So you might find an overall AHI less, but that still doesn't matter. We have to treat those patients.
We are obviously not, there is a lot more to sleep, but we are keeping it very basic. There are a lot of other...
This is just to fill the time.
Yes.
So, good evening to all. Ma'am, if I may start.
Yes, please.
Yeah, sure, please.
Yeah, so I'm coming on to the next case. Myself, Dr. Alina Varghese. I'm a resident in Jupiter Hospital, Thane. So this patient presented to the OPD with complaints of dyspnea on exertion, doses of while talking to people and in the meetings. He had a history of multiple motor vehicle accidents in the past couple of years. On detailed history, the patient had dyspnea on exertion with chest discomfort and minimal activities. He had complaints of non-refreshing sleep, morning headaches. He complained that he had lack of concentration at work, fatigue throughout the day. The patient had dozed off while driving many times, leading to the multiple accidents. He sleeps at every opportunity whenever he is idle. And he also gave a significant history of nocturia. So he had no known comorbidities. There were no medical or surgical illnesses in the past. He was a smoker with a pack year of 7. He had a desk job and he had a relatively sedentary lifestyle with minimal activity. Moving on to the question.
Yeah, the cause of dyspnea in a case of obstructive sleep apnea, do the patients of obstructive sleep apnea actually have dyspnea on exertion? What could be the cause in these patients? Any idea, Dr. Manas?
So, ma'am, dyspnea not a very typical presentation or presenting symptom of patient with only sleep apnea. So it should raise an alarm. Someone coming to us with the sleep apnea, we have already discussed the two-way relationship. We need to find out any existing systemic disorder, right, ranging from cardiac, respiratory, neuromuscular, or patient taking any medications, maybe opioid medication, which is worsening the existing sleep apnea. Or there is a separate disorder and sleep apnea both combined into the patient's clinical condition. So this is just a list of condition. We have already discussed it. We move on to
severe obesity itself can be a kind of, patients who are obese and not really working out or not really. So that is one of the most first, this one. Yeah, we can go to the next one.
Correct. And sometimes neuromuscular diseases, I think, which get missed, a lot of times where they coexistently also have sleep apnea. And they are listening. Yes.
So we examined the patient. He had a height of 167 centimeters, a weight of 110 kg, and BMI is grossly high, 39.4, a neck circumference of 20 inches. The starting feature in this patient was he had a SpO2 of 92% at room air, which is at rest. The BP was okay, 140/90. Oral examination showed only hard palate. There was bilateral symmetrical pitting edema in him.
So, Dr. Supraja, would you like to answer this? Is daytime hypoxia routinely seen in obstructive sleep apnea patient? Do we have the patient had saturation of 92?
So yeah, routinely in a plain vanilla case of OSA, you don't expect a hypoxia. But in the history, this gentleman had a 7-pack years of smoking, which was associated. So here comes again breathlessness, pack years is high. And there is a drop in oxygen level. So whether any respiratory first cause of respiratory thing has to be ruled out, coexisting things have to be thought about.
Yeah, so we can move ahead and can you go to the next slide? Yeah, you can go ahead.
So these are the reasons. Yeah,
these are the reasons.
So we did a thorough investigation for this patient. Baseline CBC was done with a hemoglobin of 18.2. Total count was okay. Platelets were okay. The RFK and LFT were normal. A 2D echo was done in this patient. He had an ejection fraction of 55% and he had moderate pulmonary hypertension. A spirometry was done. Even though he had a 7-pack year history, it is not showing much significant reflection in his spirometry. ABG was conducted. It is showing a pH of 7.37. PCO2 52 millimeters of mercury, PO2 68, which again confirms SpO2 correlating with the SpO2, and a bicarbonate of 29 milliequivalents per liter. So the ABG is suggestive of a chronic compensator type 2 failure.
So, Dr. Manas, would you like to answer this one with the ABG and other diagnostic evaluation? Do you think of any ring, any bell ring that in your mind that what the patient could be having?
ABG is suggestive of chronic compensated respiratory failure. Patient is, he's having hypercarbia on his ABG, like ABG, but he is coming to your OPD. So, we come across a set of disorders, which I would like to summarize in these slides. I would like to classify this in, two different sets based on the mechanism. There is a set called as won't breathe. Won't breathe is the problem with the boss, is the problem with the respiratory centers. Either it's the problem of the boss himself or it is the disease processes which are affecting the boss. So three broad classes, maybe a central hypoventilation, medication like narcotics and opiates which are causing respiratory depression, and third is obesity hypoventilation syndrome. We in the coming slides and coming questions, I would discuss the mechanism of obesity causing dyspnea, and there is a second set of group presenting with chronic compensated respiratory failure. These are the patients in which boss is good, but problem is with the employees. So these are the restrictive thoracic disorders. They are like severe kyphoscoliosis, even severe obesity, severe fat on the chest wall. It is classified in the thoracic case disorder. You have a neuromuscular disorder, poliomyelitis, neuropathy, neuromuscular junction disorder, and myopathies. Apart from this, you have, Alina, next slide, please. So you have the patients with sleep-related hypoventilation related to the systemic disease like asthma, COPD, bronchiectasis, severe idiopathic diffuse parenchymal lung disease, maybe end stage, severe pulmonary hypertension, and obesity hypoventilation syndrome. So this is what I would like to explain the disorder.
So, yeah, go ahead. No, go ahead. It's okay.
So we did a diagnostic polysomnography in this patient. It showed an AHI of 98, RDI 152. The lower saturation documented was 65%. Immediately after the sleep onset, the patient's saturation dropped to 85% without any onset of events, with an EtCO2 showing a rise of 10 millimeters of mercury compared to pre-sleep baseline. Dr. Manas, sir, if you want to throw some light on that.
So, as I said, only numbers are not. So AHI 98, it's already, suggesting that case is a very severe case. RDI 152, oxygen went up to 65%. These are the numbers. One more thing which we need to notice here is a pattern. Patient immediately, after the sleep onset, his saturation drops to 85%, and it persists for more than 10 minutes, 15 minutes, maybe with or without intervening events. Apart from this, that is not actually the measure, but that is telling us sleep-linked hypoxemia. Now, it could be because of hypoventilation. For defining sleep-linked hypoventilation, what ASM or what the protocols say, we need a transcutaneous CO2. But transcutaneous CO2 being a costly job, the machine itself costs 14 lakhs. We can use EtCO2 as one of the, surrogates for this. So, a rise in carbon dioxide more than 10 millimeters of mercury from the baseline state. So someone may be chronically hypercapnic, and his PCO2 baseline must be around 48. So if it increases more than 58, I will classify this as a sleep-linked hypoventilation. So patient is having sleep-linked hypoxia with hypercapnia confirmed by EtCO2. So, combining them, I conclude here that patient, apart from having severe sleep disorder breathing due to OSA, is also having sleep-linked hypoventilation. Next.
So, there are just a couple of points that I would like to bring into over here. The fact that we mentioned ABG in the beginning. Most of the time, what happens is these patients come with the sleep study report, or, then you would do, because ABG is not freely available in all the patients. So obesity hypoventilation syndrome is diagnosed with the 4 cardinal things. One is obesity, more than 30. Second is presence of CO2, high CO2. And the third one is the presence of obstructive sleep apnea or sleep hypoventilation. So these things together will make it into obesity hypoventilation syndrome. The point I'm making over here is that what are the kind of things that you would suspect that the patient has obesity hypoventilation syndrome? The low saturation in the night plus severe obesity plus severe obstructive sleep apnea should alert the physician to go ahead with ABG. When do you do ABG should be important and should be kept in mind, that when the patient has severe obesity, patient has severe obstructive sleep apnea and low saturation in the daytime should alert the physician to go ahead with ABG. Yeah, you can go ahead with the next this.
So as sir mentioned, we have already discussed this.
Yeah.
So what is obesity hyperventilation syndrome? As ma'am rightly said, presence of obesity with a BMI of more than 30, chronic hypoventilation with daytime hypercapnia, awake PaCO2 of 45, sleep-related breathing disorder in the absence of any other causes of hypoventilation. So these are
we have to rule out all other possible causes of awake hypoventilation before labeling a patient as OHS.
Correct. So I think here as everybody is mentioning, basically it's in a patient who is a very high suspicion of sleep apnea, who also has daytime hypoxia, right? So those are the patients where your threshold for doing an EBG would be low, and investigating the cause for a type 2 respiratory failure, basically compensated type 2 respiratory failure. You will go into all your algorithm of COPD, respiratory disorders. You are looking at neuromuscular disorders, kyphoscoliosis. You will rule out all of that before then you come to a dedicated sleep study, which will help you then in figuring out what is that. This is obesity hypoventilation.
Right. And this slide, Deepthi madam, this I had kept for the question you had: how does obesity, how does a severe obese person present with dyspnea? So not all OHS patients will have OSA. There's a phenotype. OHS patient might not have severe OSA, and not all OSA or severe OSA patients will have OHS. So this is the slide which explains everything. It is a bit complicated. I will make it simple. What does morbid obesity do? It puts a lot of pressure on the chest wall. Definitely, it will affect the respiratory mechanics. The first point. Second, obese patient has high requirement, high minute ventilation, high metabolic rate. It increases the work of breathing. And apart from this, they have sleep apnea. So, how do the muscles perform? So if muscles, every person is different. So if muscle endurance is good, patient might still have just sleep apnea and a normal ventilation. And there is something called as leptin and respiratory drive. It depends on the respiratory center. Every human has a respiratory center and it has its own personality. So, if it can cope up, if it has a high sensitivity, it might, a patient of severe OSA still, might not have a sleep-linked hypoventilation or OHS. And last is the, hypercapnic respiratory drive. This is more into physiology. We will go into more of physiology about the plant gain and loop gain. So basically, to conclude this slide, it's not every morbid obese patient and severe OSA might have OHS, and OHS also has phenotypes of one with severe OSA and one with maybe not that severe OSA.
Sure.
So, Dr. Supraja, would you like to quickly answer this question? Would a limited channel pick up this kind of problems? A, and B, one more thing I want to make you draw one importance of soda bicarb, or presence of bicarbonate level in the blood. So can you mention on that bicarbonate part a little bit? And
so coming on to limited channel, so as we had already discussed, severe OSA will be missed out, or unless the neurological component, if you miss out, you can miss out on a severe OSA. So ideally in these patients, a full channel, a level 1 study is the ideal one to go about. And so we might miss it on a home-based study. And second thing, when you do not add a ABG to the current testing, you will again miss out on these, because one, all of us are having a SpO2 probe in every clinic, but ABG, as pointed out, unless you do the blood gas, you wouldn't know whether there's an increase in the carbon dioxide. And second thing is the importance of bicarbonate. So whenever there is an increase in the CO2, the pH is going to drop. So correspondingly, your bicarbonate has to increase to compensate. So then we have it as a compensated and an uncompensated. So if it's an acute event, then the bicarbonate levels are not going to go up. But if it's a chronic event, if the patient has been living with a low oxygen and a slightly higher carbon dioxide, then the bicarbonate levels are going to compensate enough for the pH to maintain in the normal range, which is 7.38 to 7.42. So the ABG as a whole has to be looked into, whether it is acute or chronic, and whether it is a respiratory or a metabolic, and whether it is compensated or uncompensated. So it's a very simple test, but it gives a lot of information as to how the milieu has been happening in the body.
so bicarb can be used as a kind of a biomarker, or a kind of a screening tool for finding out the patient in patients who have bicarbonate more than 27 should go ahead with doing an ABG. So that was what I was trying to.
I think that was anyways your last couple of slides, Alina. If you want to just round up your case based on this discussion, because we are already past 9 o'clock.
Yeah.
Manas, would you like to just wind it up and tell us what is your diagnosis finally on this case?
The question was, would you, just in one line, would you choose a limited channel sleep study for this patient? Never. Because I would miss sleep-linked hypoventilation, which is the diagnosis for this patient. And considering the severity, the recommendation is against going for limited channel study. Last thing is to summarize my case. What we evaluated the patient's X-ray, we evaluated respiratory system, we ruled out respiratory causes of the hypoventilation, chronic compensated hypercapnia. From the spirometry. 2D echo is suggestive of moderate pulmonary hypertension, RA, RV dilated, RV hypertrophy. So core P is what I could conclude. Group 3 pulmonary hypertension. And what is the cause? So one of the very important cause. One is patient is also having polycythemia. I didn't mention the hematocrit, but 18.2. So, we get referrals for evaluation of polycythemia also, for sleep-linked hypoxia or sleep-linked hypoventilation disorders. So patient is a case of severe sleep disordered breathing with severe OSA and sleep-linked hypoventilation, plus, as madam mentioned, ABG is suggestive of obesity, awake alveolar hypoventilation. So the diagnosis is obesity hypoventilation syndrome with core P, core pulmonary.
Okay.
Right. So I guess Dr. Pratibha, you would like to.
Yeah.
give
So I
me-
think, basically what these two cases that were being discussed were very classical cases of obstructive sleep apnea, and the second case was of obesity hypoventilation syndrome. And while there are all these, the awareness about the level of study that you're asking for, what is a recommendation? I think that is what this webinar wanted to highlight, is that everybody will not benefit with a limited channel or a level 1 study that we do at home. There are specific criteria that when you have a patient who has comorbid conditions or unusual presentations, then especially like the second patient who had resting hypoxemia during the daytime, and we would have missed these cases if we had just done a limited channel home study. So there are, yes, you have the studies for screening purpose when you have a very classical case where you want to do it, but anything that you are not getting the information that you're looking for in your home studies, your limited channel studies, the recommendation is very clear for complete polysomnographies and in-lab studies. And that's where we should also, tie up together to first diagnose these patients better. Referrals from physicians will definitely help in figuring out all these complex cases. There is much more to sleep apnea than we have discussed today. There are many, many, many more aspects. However, due to limitation of time, we have not been able to study all the aspects, but we've studied two classical scenarios that will come into your clinic. And we are hoping that we'll have more interaction with you all now after this kind of a webinar. And we are going to meet again in 2 weeks, where we are going to follow up these cases about how to manage these cases on 24th of June. So hope you all will join us then. I must thank Dipti for, she's in the US, but she's adjusted her time so that she can join us for this webinar. Thank you, Dipti. And thank you, Supraja and Manas, for your excellent inputs. And of course, Anshu and Alina for your great presentations and your cases so that we could have this discussion. I must thank Glenmark, our partner for sponsor partner for these webinars, and API for helping us coordinate with them to take this forward. Thank you, everyone. Good night.
Thank you. Thanks.
Thank you so much, ma'am. Yes.
Thank you.
Tell us when you are logged off.